Okay, our next speaker is Dina Katabi. Her research spans digital health, wireless networks, mobile computing, machine learning, and computer vision, looking at issues of congestion control, network measurement, scalability, internet pricing, routing, wireless networks, and network security, all sorts of things. She has a particular interest in adapting tools from various fields of applied mathematics, such as control theory, coding theory, and AI to solve problems in computer networks. Let's welcome Dina Katabi.
Hi, everyone. So like Mark, I was a student here at MIT, and actually what used to be LCS, and I see many familiar faces here from back the LCS phase. And I guess like Mark, I found my technical love. But unlike Mark, who got married to that technical love of robotics for the rest of his life, I guess I was more promiscuous in the sense that I moved from one technical love to another technical love. But what is interesting for me is that before actually coming to MIT, I entered med school because in Syria, where I come from, there is no pre-med. So I went to med school. I was distanced. I was from a family of all medical doctors. So I went to med school and was interested, but just like, oh, I cannot live the rest of my life without math and like engineering. So I switched. And actually, when I came to MIT, the first time I arrived in MIT, I was doing neural networks with Eric Grimson. And then it was the AI winter. So I decided, that's not really where I want to be. So I switched, and I see David Clark in the audience, my PhD advisor. So I worked on computer networks, and then moved to understanding wireless signals. And then did so many things, and eventually landed back in medicine and neural networks again. So, I mean, life goes on in cycles, and it's really a very interesting environment here at MIT where we can take all of the knowledge and consume it, synthesize it, and bring it together. And today, I want to tell you about some of this recent topic that I've been working on for the last maybe 6, 7 years, which is data-driven, AI-powered healthcare. Now, it's not just me. In fact, everyone that you talk to about the future of healthcare and drug development and all of biomedicine, they tell you that the future is going to be about data-driven. It's going to be like we are going to get data from patients about their symptoms, the evolution of those symptoms, so that we can understand exactly what's happening with them. It's going to take that clinical data, process it with machine learning to get insight so that we can detect problems before actually they exacerbate and happen. We can intervene and avoid hospitalization and ER visits. But to do all of that stuff, we need the clinical data. Where do we get clinical data today? It looks like this. If you want clinical data from patients, you either stick a needle in their body, or you strap them to a machine or strap sensors on their body, and you collect the data. Now, I don't have to tell you that this is not a happy experience for them. But not just that. In fact, the type of data that we get today is very episodic data. We get some data whenever somebody goes for a test. Get blood tests every 6 months, year, something. So it's very episodic data. We don't have the ability to dynamically track the evolution of diseases and symptoms in patients. Now, what if someone comes and tells you, we're going to just use the radio signal around us to collect clinical data about patients. Just you guys now are just swimming in electromagnetic waves around you. Well, if we can just analyze radio signal as they bounce off a human body, use AI and machine learning to process that data, and do it all the time in people's home as they live their life. What kind of data do we get, and what can we do with it? So This is exactly actually what we have done over the past few years. So basically, we take the radio signals that bounce around in the home and bounce up the human body because our bodies are made of water. Some of these reflections come back to our device. We analyze them. In this case, we detect a fall, can detect and can alert the caregiver via text, email, or phone call. Now, of course, this is just an illustrative video. So let's see what we can do with real people. So here what you see, the big frame is what the radio device sees through a wall. And that picture or video that I'm going to play for you at the top here is what's happening inside the room. So imagine if someone from behind this wall is monitoring us and discovering our motion. So let me play this for you. And you see as he sits on the chair up there, you see that the radio nose has a skeleton sitting on the chair, stands up, follows him through the wall just purely based on how his body is changing the radio signal around him. When he moves with his right foot, it discovers it. When he moves with the left foot, it discovers it from the radio signals. Of course, everything that we do, we compare to the ground truth. In this case, will be like something called the motion beacon detection room. And we show that it is highly accurate, completely contactless through a wall. So we are very excited to be able to track motion. But what else we can do? So when you go to sleep, your brain waves change, and you enter different stages: awake, light sleep, deep sleep, and rapid eye movements, or REM. Now, these sleep stages, of course, are very important for sleep disorders. And we know 1 in every 3 Americans has problems with sleep. But it's not just that. In fact, almost every single disease, and definitely anything that has to do with neuroscience, very much is related to sleep. So just to give you an idea, for example, the slow waves during deep sleep and impairment in the slow wave is highly related to Alzheimer's disease. REM, rapid eye movements, is a stage during which typically we dream. And one of the known symptoms in depression is that REM tends to happen early on in the sleep, too early. So imagine if you can get these sleep stages accurately every single night from the patient. Now today, if you want to get accurate sleep staging, what do? You send someone to a sleep lab. They put these electrodes on his head and body, and they ask him to sleep like this. This is actually from MGH Sleep Lab. And you can see from the face, this is not a happy experience. So, but it's more interestingly, this is actually how we evaluate sleep. And like it's hard to imagine that this is representative. I mean, for me, if I sleep in a different bed, I'm not going to sleep the same way. So imagine sleeping with all of these electrodes on your head and body. Let me show you what we are able to do. So this is our device. Transmits very low power wireless signal, analyzes the reflection using machine learning, and spits out the sleep stages throughout the night. This is actually something called a hypnogram. If you go to a sleep lab, this is what they give you. For every 30 seconds of sleep, they tell you, this is light sleep, this is deep sleep, this is REM. And this is like by having sleep technician looking at all those signals and manually tracking what's happening to you. And of course, everything that we do, we compare with the gold standard. In the case of sleep is, of course, that stuff with all the electrodes on the head and body is called PSG. I want to show you just one example for people to understand like how sleep is evaluated and how does it look. So here you can see this is PSG, which is a gold standard. This is our prediction. Don't ask me why emerald. Like emerald is our device, but I mean, it should be in green, of course, but my student had problems with colors. OK, but regardless. So this person went to bed around 0, which is midnight. And for 2 hours, actually, he wasn't able to fall asleep. So you see the signal stays around awake. And then around 2 a.m., so just before 2 a.m., he fell asleep, moved to light sleep. Then there were like excursion to deep sleep. And then again, he's awake from 2:30 to 3:30. And then he falls asleep, light sleep, deep sleep, and then REM. So you see 1 sleep cycle, 2nd sleep cycle, 3rd sleep cycle, 4th sleep cycle. And as you can see, the 2 graphs are very similar. In fact, most of the differences come from areas like this, where a sleep technician looking at your data in sleep lab might go back and forth. No, I think this 30-second is light sleep. No, this next one is deep sleep, light sleep, deep sleep. Well, if you have a neural network, it likes to consolidate the data, as you can see here. But overall, you can get sleep architecture very accurately, actually, with radio signal every night in people's own homes. This person is sitting like here, guys, and what you see on the screen is nothing but his inhales, exhales. We ask him to hold his breath, and you see the signal is going to stay at steady level because he exhaled, he did not inhale. And again, everything that we do, we compare to the gold standard. In this case, is an FDA-approved device that you have to wear on your chest to monitor your breathing. So over the last 3-4 years now, we have been working with medical doctors in hospital, in pharmaceutical industry, biotech, and as we are speaking now, our devices actually, hundreds and hundreds of devices are deployed with people who have Parkinson's disease, Alzheimer's disease, autoimmune diseases such as Crohn's, lupus, atopic dermatitis. At the time of COVID, we deployed also with COVID patients. And they are collecting, as I'm speaking to you guys, these devices are collecting data about patients' diseases and the evolution of symptoms. So once you have that kind of powerful data continuously, clinical data from patient homes, what can you do with it? And I'm going to use Parkinson's as an example to show you that. So Parkinson's disease is the fastest growing neurological disease in the whole world. It is the second most common disease after Alzheimer's in neurology. I mean, we all know Parkinson's. Basically, there are the tremors and the stiffness of the motion. So let me show you some of our results in Parkinson's disease. So let me just show you a video. So this actually is a patient. This is our device. And as you can see, just uses a radio signal from the environment. It steps back to the background. The person doesn't have to do anything. When the patient moves, it tracks its motion. Here you just see the motion as a dot on a floor map. And it's tracking how he's moving throughout. Now, this is 2 hours trajectory from a particular Parkinson patient. And you can see he moves between the bed, the chair. This is actually a person who lives in an assisted living community. So you can see he has a bathroom. He has actually a kitchen area here. So if you have that data from patient, what do you know about their lives? So let me explain this graph. This graph actually is for the patient on the previous thing. Every circle here is 1 day. The innermost circle is the first day of the study. The outermost circle is the last day of the study. This is 2 months of data. 0 is midnight. This is noontime. So look at the blue here. Blue refers to the time he is asleep in bed. So at the beginning of the study here, the inner circle, you see that blue is very fragmented. So his sleep is actually a disaster. As we continue, you see the sleep is consolidating and is improving. And we know in Parkinson's, sleep is a big problem. Now, what else you see? You see a cone of yellow here around 8 a.m. in the morning. So yellow means that he's entering the bathroom for his toileting and showering. Now, when me and my students saw this, like he entered the bathroom around 8 a.m., but he actually wakes up around 3, 4 a.m. You see the blue stops. He sits on a chair. Green is referring to a chair. And until 8 a.m. to go to do his showering and toileting. That was very surprising. And it's like you wake up, you typically go have a shower. Why would anyone do this? Okay. I'm told 2 minutes. So basically, he does this because actually he's unable to do his showering on his own. So that was a surprise, I mean, basically to the doctor. It's like, oh, wow, he didn't know that the patient was that sedentary and dependent on his caregiver who arrives exactly at 8 a.m. to take him to the shower. So by having a smart Wi-Fi-like device in someone's home, you are tracking their behavioral symptoms and being quantitative about it. But we wanted actually to tie this to the gold standard in assessing Parkinson's disease. So what we did here on the x-axis is something called the MDS-UPDRS, which is the gold standard in assessing Parkinson's. And on the y-axis is this gait speed measurement from these patients. And each dot is one patient, and you can see there is very high correlation between this gait speed that we see and the gold standard in how you assess Parkinson's today. But this gold standard actually it takes like about 2 hours from a clinician, and it requires the patient to go to the hospital, and it has high noise. Particularly, and it's difficult if the patient doesn't live next to a Parkinson's center. So the implication of what we are seeing here, if you use the gold standard today to actually do a clinical trial, and so you have on the x-axis the drug effect size. On the y-axis is the number of participants that you need in your clinical trial to get statistical significance. You will need, for 1 year of clinical trial, about 11,000 patients. That's huge if you are developing drugs for Parkinson's. Here is how many patients you need for the same statistical significance if you are in drug development for Parkinson's. Just an order of magnitude fewer patients and less cost for your clinical trial. But most importantly, we wanted to see whether we can diagnose Parkinson's disease early. Because the biggest problem in Parkinson's disease is that we diagnose Parkinson's about 10 years after the disease starts in the brain. And by the time we diagnose Parkinson's, there is a huge impairment of the dopamine capability, which is the main thing underlying Parkinson's. But the reason, why the diagnosis is very late is because we rely on the motor symptoms, the tremor and the stiffness in the motion. So if we want to diagnose Parkinson's early, we need to diagnose Parkinson's without the motor symptoms. So we asked a very simple question. Can AI detect Parkinson's disease from breathing, nocturnal breathing? What do you guys think? Sure, yeah, this is the MIT crowd, of course. And the answer is sure. So we trained a neural network to detect Parkinson's from breathing to answer 2 questions. Does this person have Parkinson's? And if they do, what is the severity of their disease? And this is a very large trial with data over 7,000 patients from Mayo. We collaborated with Mayo, MGH, University of Rochester. And here is the empirical result. And this is actually from wireless signal that is reflected of their body. And then from that, we get the breathing. And then we detect whether they have Parkinson's or not. And you can see the AUC is 90%. So you can think of it that with 90% accuracy, we can tell whether somebody has Parkinson's or not just from their breathing. And that opened up this opportunity to be able to detect Parkinson's before the motor symptoms evolve. So I'll stop here. And hopefully, when you count for 100-year anniversary of CSAIL, hope all of you can make it at the time. You will see completely new words for how healthcare uses machine learning and technology. Thank you very much.